Good evening. This is Dr. Bill Wyatt again with the American Orthodontic Society. And by the way, you can join the American Orthodontic Society from wherever you are in the world. If you can hear these videos, or we've got some excellent teachers now that are starting to do these programs around over the world. So I hope to see some of them there. So this evening I want to discuss a more advanced TMJ problem that a young lady had, and she required both upper and lower splints to correct this. Now, if the damage to the temporomandibular joint is, a blow, somebody hits you in the jaw, and it pushes the condyle into this retrodiscal tissue. If it just does it a little bit, it's inflamed and swells up and hurts. And if you give them some medication to lower the inflammation or heat and ice and stuff, it helps it. But if it's a damage that just continues every time they chew, it pushes the condyle into that tissue and it gets so sore and everything, then you've got to do something to bring the jaw forward so that the condyle doesn't go jamming into the retrodiscal tissue hard. So that's kind of the thing in a nutshell. So some people have to have a upper retainer or a splint, with a big ramp that pulls their jaw forward. And then if you do, you have to have some kind of lower splint, that keeps the jaw out there during the day. You can't run around with this big thing hanging down in your mouth. Not very many people can. Let's get on now and look at this young lady. I'm sorry I got a bad shot of her back then, and she's got a nice facial set up here. Everything's very nice and a nice smile, but she's got and the profile is good, but the dental situation is a little off, and it's causing, or something's causing this TMJ problem, and it's more serious than usually we run into. You see the midline's off. Now, over on the right side of the mouth, she is missing 2 teeth in here, and on this side, both the first bicuspids apparently are missing, and the teeth have moved forward. And this is a class 1 relationship here with the lower jaw out in front of the upper jaw and all this good stuff right here. It's lined up pretty good. Now on the opposite side of the mouth, things are a little different. She has all the bicuspids up above, but is missing this one right here. So this throws this molar out in front of the upper molar a long way, and it kind of twists the jaw a little, and that could have some effect on the condyles where they fit in the fossa if the jaw is off to one side some way or another. We don't know exactly what is bringing it about. She could have stress and a lot of other problems too. And so we go in here to treat this young lady, and I didn't do the TMJ treatment. Dr. Charles Holt did that, but he sent her over to me in a splint, in both upper and lower splints, to get her out of the splints and back into where she didn't have any trouble with her jaw joint. So this is the problem. Now you can see the head of the condyle right up in here. You kind of visualize where it is, and this retrodiscal tissue is kind of behind it. And if you get jammed in the jaw, man, it'll shove the condyle into that highly vascular tissue right up here, and you can have trouble for quite a while. But when your pressure goes off and the thing settles down, the condyle's not bothering it, then you can, just do some medication and get rid of it after a while. But if you've had it for years and just keeps on hurting after that, the condyle goes into this just on your swallowing and chewing and everything. And it has to function, and it begins to hurt. And then you get pain all over the neck and the shoulders and the headaches and all the different kind of stuff that comes with that. So let's go on and show. We put a splint in, or Dr. Holt did, and now she's missing those teeth. And you see how this tooth is sticking off the side back here, and this one is more normal, but the midline is off a little bit in here. So let me, and on this one, you show where we've moved the teeth forward on this, and we still have not removed one of those upper bicuspids. The wisdom teeth are already gone, and so you got a little problem there. So here we have the same thing is coming off. This is 1993, and she's age 43 at this time. And we took transcranial x-rays on people, nearly everybody that had TMJ problems. And you can see the condyle on these real good. And here is the fossa right in here, and here's the ear right here. So it's real close to the ear. Now, when the condyle goes back, it's back here, and you see the fossa here, but it doesn't go up to the top of the fossa back at this, and this is where that tissue lies, you see. And here it is at rest, and let's see, one of them's at rest and one of them's biting, just not putting any pressure on it at all. And the condyle is in the fossa. Okay, and so you can't really diagnose the thing from the x-ray. It's just impossible to do that. You can see it, and let me go back in and erase those. You can see it, but you can't tell. You can see sometimes where it is close to the edge of the, like this is partially open, looks like. Okay, and then we'll go on here to the next transcranial. But we do the transcranials on everybody that we work on their jaw joint, or try to do that to kind of protect yourself and everything. Now, her teeth fit together back here. If you back them up, they'll come together good. But if you do, that pushes the condyle back into that highly vascular tissue, and she has a problem with it. So we have to bring her jaw out to this point where she's almost edge to edge in the front. And now we open the bite, and we've got a space between the teeth here. Now, if you tried to chew out here and stay out here all the time, your force is here, and it's back in the joint, on both joints back here. They take a tremendous amount of force. The muscles are closer to them, and so they put a lot more force on the joint than you do on your teeth out here. And it's amazing how they hold up at all, but they do. I'm 92 and going on 93, and my function's pretty good on there. I've damaged this one, and sometimes it'll hurt, but then it kind of clears up. So anyway, the tissue's very, very tough, and there's no blood vessels and no nerve endings in the center part of that disc. Okay, we have to pull her jaw to that point to give her relief and get rid of the pain. And so that, all it does is just pull the condyle so that it doesn't go all the way back here, it stops here, say. And so that leaves this tissue alone. And I've had people just get better overnight, like in some miracle you work. But all you did is pull the condyle forward out of that tissue, and many of them just, the pain goes away almost immediately. Now, let's see the splints that we use to do that with. Now, in this case, we have to use a big ramp up here in the front to keep the jaw to during the night. But during the daytime, she had to wear something back here in the back that takes the load off of the teeth. In other words, she couldn't stay up here. You'd be loading the joint, so you put a deal in that's got some occlusal forces against these teeth back here, so that when you bite to, the load is on the teeth up here rather than on the temporomandibular joint. And that's the thing in a nutshell. If you can just get that down and look at those pictures in that school in Sweden. They're the most informative things that I've ever found to teach you something about the temporomandibular joint. Okay, this is a lower splint that she can wear during the daytime, and it'll make her keep her teeth in this forward position, or it tries to. Lower splints do not have the ability to keep your jaw forward that upper ones do. So here is an upper splint, and if you wear this thing, you can't close anyway, but your teeth hit here and you have to close them up into this spot right here. Now, you make this ramp on there, and you've got to have her kind of relax and try to push her jaw back. If you get the teeth coming up behind this and they bite up there, it shoves the jaw back tremendously. And I've had that happen to me a few times. So you must make the ramp where they can't possibly go behind it during the nighttime. And as they swallow, it brings the teeth forward up here, and you keep off of that retrodiscal tissue, and the things will get better in most every case. Of course, you can have arthritis and severe trauma and things that couldn't do that. So this is an upper forward positioning splint that makes you bring the teeth out, so something like that. And that worked on this young lady. So we had to get her upper teeth, excuse me, we had to get her upper teeth where the upper and lower teeth would fit together, where she could chew better, but the condyle was forward. In other words, get the jaw out there where it fit better and stayed off of the condyle would stay off of the tissue. So here we have a closed bite situation, so we have to put this wire here. This is an intruding wire. We've got videos on it and the flexible wire in here, and I think we may have put something on the upper, but I don't see it on this picture here. But we intruded these teeth. You see, these were a certain level back in here. Now we bring these down about this, and the jaw can close further forward. So you can watch it do that. Now, there bad is that lower splint, and this is the upper splint in there, and we're pushing this down with the lower splint in there, but it makes it where it doesn't fit good. So we didn't do anything to the upper, just had the splint on it, or you couldn't, with that splint, you can't move the teeth around while they're wearing the splint, but you can the lower one enough. All right, we continue closing that bite until we got it down where it was level. And now we come in and take out that other tooth down here so that it balances the occlusion. And so you can see we're closing the space where that tooth was. Now, here we've closed the bite, and we come in and take her out of the splint, and we put braces on the teeth, and you see these teeth are right where they were, and these now are virtually touching back in the back. And so this is coming out of the splint, and this is a little more complicated than the ones where you just have to use an upper splint at night or something. All right, here we finished. This is in 1993. It's a little midline is off to the side, and there may be some problem with the size of the teeth or something of that nature in doing that. I don't worry about having a little midline. We were a little late extracting that one tooth over there. And here it is from that side in 93. And on the left side, 93 again. And we started it back in the 80s. Now, in this particular one, I used an upper and lower retainer. And we can make our retainers where they have ramps on them. And so this is not much of a ramp, but we bite in here with the lower teeth, and that holds them there. And they usually get over the problem with the temporomandibular pain. And we have the lower now is, I take it back, we did not take out that tooth. This is a lower. We put a lower kind of retainer in there. It kind of works like a splint a little bit and keeps those teeth in line. I didn't want to take a chance on them moving out on us. So anyway, this is a nighttime splint or a nighttime retainer that has a ramp on it. So she wears this one at night and one in the daytime that doesn't have this big ramp on it up here in the front, which you just can't hardly work and talk to people with something like that. Now that's a nighttime retainer with a ramp on it. And that's the end of this. And I hope you get something out of it and learn that you can deal with these rather advanced TMJ problem cases. Now the ramp situation here may scare some of you off, but the problem is just get the jaw forward, get the condyle off of the retrodiscal tissue, and just put the teeth together where they fit out there. I hope you get something out of this, and if you do, join our group and subscribe to our channel, and we appreciate your watching. So I'll say good night, and it is night here now. Thank you very much, and I'll close out.